It's Dr. Rosenberg again. Today I wanted to discuss carpal tunnel syndrome. This is a very common problem and a very misunderstood problem, and a problem that I have seen poorly treated in many respects. Carpal tunnel syndrome is a pinched nerve in the wrist. In your wrist you have a tunnel, and through that tunnel passes the flexor tendons that control your fingers, as well as one nerve, the median nerve. The median nerve, for the most part, gives strength and feeling to your thumb and next two fingers. If that nerve gets injured, it swells. It's no different than if I punched you in the arm. Your arm would swell. The difference is you wouldn't move your arm for a few days, and the swelling would go down and you'd be fine. The problem with carpal tunnel syndrome is that once that nerve swells, the walls of the tunnel now provide an irritation to that nerve. And every time you as a human being move your wrists, it scrapes the nerve on the top of the tunnel, and the result is the nerve never heals. The surgical approach was the first approach used to this, and it's quite straightforward. The surgeon will cut a hole in the top of the tunnel, relieve the pressure. The nerve now can go back down to its normal size, and everything for the most part is fine. Except that surgery is surgery, and sometimes there are some complications that we would prefer to avoid. You can have scarring. You can have infection. They could accidentally cut the nerve. You could have some sort of reaction, keloid formation, etc., etc., etc. And the truth is, probably 1 out of 10 patients have some sort of post-surgical problem. The difficulty, of course, is if you're that one patient, you don't care about the other 8 patients or 9 patients. You're the one with a problem. So we have pioneered a non-surgical approach to carpal tunnel syndrome. And in studying this issue, what we have found is that there is no consistency in what other physicians prescribe for non-surgical management. Sometimes they say wear a splint at nighttime. Sometimes they say wear a splint at daytime. Sometimes they say wear a splint when it hurts. Sometimes they tell you to do exercises. Sometimes they tell you to do nothing. It's a very confused mishmash of non-surgical management. So what we did was we set up a protocol. You wear a splint 24/7 for 3 weeks. You come in for therapy. That therapy is designed to reduce swelling. That means it's electrical stimulation and massage. It is not ultrasound. It is not wrist exercises. I cannot tell you how many patients come into my office. They tell me their physical therapy failed, and I say, what did the therapist have you do? And they proceed to show me wrist exercises. And my question, of course, is how do you treat a repetitive stress injury with repetitive exercise? That makes very little sense to me. And the result is the failure of the conservative management and the ultimate surgical procedure. Our practice, because we've standardized it, has managed to turn out about 9 out of 10 patients doing fine, pretty much the same as surgery. The big difference, however, is that if you fail our program, you can always have the surgery. If you have the surgery first and have a complication, it becomes a much more difficult problem to treat. I look forward to working with you.